So we're going to talk about pulmonary hypertension. So I'm going to talk quite a bit about hemodynamics and pathophysiology of pulmonary hypertension, because once you understand that, the rest just flows and makes sense. I'm going to touch upon the World Health Organization classification. And this is an expert panel in pulmonary hypertension. These different groups of individuals meet periodically every 5 years or so to update this classification, because there's many different types of pulmonary hypertension. The one that's the coolest and the most exciting probably is pulmonary arterial hypertension, but thromboembolic kind is pretty cool too. And the reason why those two different types are cool in my mind is because we can treat them. Everything else is not so easy to treat other than lung transplant if the patient is a candidate. In terms of the diagnostic approach, what you got to remember is echo first and then right heart cath. So all of these patients should get an echo followed by a right heart cath. Therapy, what I want to let you guys know is that there's many drugs available, but should be really administered by someone who routinely takes care of patients with pulmonary hypertension, as opposed to somebody who does it here and there on the side. If you have a patient with PH in your community clinic or in your hospital clinic, university clinic, excuse me, you can co-manage the patient with a PH specialist, but always do it in conjunction with a specialist is the take-home point. So the most recent World Health Symposium was in fall of 2018, and the most recent guidelines came out in January 2019. So probably in another couple of years, we'll have more updates. What you guys might not be able to follow routinely or see routinely is that pulmonary hypertension updates tend to be published either in the Journal of American College of Cardiology or in the European Respiratory Journal. That seems to be the general place where these updates go, so you might miss them if you're only looking at the New England Journal or the American Respiratory Journals. The first takeaway point is that not all pulmonary hypertension is created equal, and truly pulmonary arterial hypertension is one very specific subset, and it's really only a minority. We really don't know how many patients nationwide, worldwide have PH, but I am sure we're undercounting it. It's under-recognized and therefore it's under-treated, but PAH is truly a subset and a minor, small subset of PH as a whole. So let's talk about pulmonary hemodynamics. Normal pulmonary pressures are roughly about 14 millimeters mercury, and that's the mean pulmonary arterial pressure. And when we add in the two standard deviations of 3, the upper limit of normal becomes 20. And in the most recent symposium, the definition of pH was updated to 20. But for our purposes right now, a normal pulmonary arterial, mean pulmonary arterial pressure is 14. And when we, in hemodynamics in the ICU, whether it's cardiac critical care or medical critical care, we talk about mean pressures, because mean pressures are truly the perfusing pressures. And also in a normal pulmonary circulation, the pulmonary vascular resistance is extremely low. It's less than 2 Wood units. This is as opposed to when we talk about systemic vascular resistance, and that's like in the thousands. And the difference there is not just the value itself, but it's actually the units that we use. Joules is what we should be, dynes is what we should be using for systemic vascular resistance, and that's the metric system. Whereas in the world of pH, it seems like we're a little bit more non-metric. I won't use the word old-fashioned. We're stuck in using Wood units, but in pulmonary circulation, we talk about PVR less than 2 being normal. And if I were to convert it to dynes, that's multiplied by 80, it becomes 160. Okay, so 160 pulmonary circulation in the thousands for systemic circulation. So that gives you the sense that the pulmonary circulation is incredibly low resistance and a high flow unit. The entire cardiac output goes through the lungs, and therefore it's a very low resistance circuit. The implications of that is that the right ventricle tends to be a weak ventricle. It's not particularly strong. It doesn't have to work very hard, whereas the left ventricle has to overcome significantly elevated pressures and resistance. So the left ventricular is muscular, and in contradiction to that, the right ventricle is very thin-walled and relatively weak. So it's not meant to generate high pressures just physiologically. There's a lot of spontaneous variation. I could do a right heart cath on one of you guys in the morning, repeat it in the afternoon, and your mean PA pressure in the morning could be 10, and in the afternoon, hopefully it'll be no more than 18. But that degree of variation is to be expected. With exercise, we tend to increase our cardiac output if we're really exercising, and to compensate for that, there's a significant recruitment of pulmonary vasculature. There's a lot of the pulmonary capillaries that lie dormant in a sense, that they're not high flow most of the time, but when you start exercising, you will recruit that pulmonary vasculature. So there's a lot of reserve in the pulmonary circulation, and it's because of this very large reserve, pulmonary hypertension does not get diagnosed until that reserve is quite lost. Initial manifestation of pulmonary hypertension is dyspnea on exertion. Most patients will start feeling out of breath with exertion, and that's because they're losing their reserve to recruit that additional vasculature, because that additional vasculature is being destroyed or lost for whatever reason. Other interesting things is that, as expected, the pulmonary arterial occlusion pressure, your wedge, will go up, and your mean PA pressure will go up. There is a story of Lance Armstrong, the cyclist, being put on a bike with the swan in place. He was able to not only increase his cardiac output to God knows how many liters per minute, but his mean pulmonary pressures went up to the 60s. And that's because he is physiologically trained to do that. And in super athletes, trained athletes, high PA pressures are to be expected with exercise. But any of us mere mortal human beings, our mean pressure, PA pressure, should not go up too high. Okay. So how do we define pulmonary hypertension? Going back to this definition here, I don't know if you guys can see my pointer. Mean PA pressure 14 plus 2 standard deviations gives you a mean PA pressure of 20 of max at rest. Anything above this, we're going to call you pulmonary hypertension. We're going to call you abnormal. So to be diagnosed with mere pH, we don't need any other qualifiers. But nothing is mere pH, so we're going to talk a little bit more about that. Any one of you in the audience recognize this equation, voltage equals current times resistance? It's the Ohm's law. I'll give you the answer. It comes from physics. It comes from electrical engineering. It comes from I call it the basic equation of life, because this is what we're going to apply to the human body. And if you remember V equals IR, you can think about pretty much any equation in the human body. Let me not say any equation. I'm not going to talk for our nephrology colleagues, but pretty much everything else, brain perfusion, kidney perfusion, liver perfusion, V equals IR is it. The way we think about this is that pressure starts at a high point and it goes downhill. So you're starting off at a high point, you're going downhill. As you're going downhill, you're encountering resistance, and this resistance will wear down the pressure, and you end up at a lower point of pressure. P1 to P2, or delta P, is equal to flow times resistance. And in the human body, flow is cardiac output. Resistance is going to depend on if you're in the pulmonary circulation or you're in the systemic circulation. Obviously, if you're in the pulmonary circulation, is pulmonary vascular resistance. Systemic circulation is SVR. And this is a demonstration of that. Without getting your eyes glazed over too much, the pulmonary circulation is going to start here in the pulmonary artery, leaving the right ventricle. So mean PA pressure is your starting point. And your ending point, P2, is actually your wedge, because we cannot measure pulmonary venal pressure at the capillary level, but we guesstimate it from the wedge or pulmonary arterial pressure. And you start off at P2, mean PA pressure, you lose pressure as the cardiac output goes down, and you're left with a wedge. and that's your pulmonary circulation. Similarly, your systemic circulation is going to start in the aorta. So your mean systemic pressure, or your MAPS, is your starting point. You're going to go through all the various organs, etc., and you're going to end up with the distal capillaries. And since we don't measure pressure in the distal capillaries, we approximate it by the right atrial or CVP pressure. All right. So visually, you can think about these two different circulations. They are actually truly separate. The only interconnection with them that matters truly is the interventricular septum. So in pulmonary hypertension, you'll see a right ventricle that's huge and will bow over into the left ventricle and compromise cardiac output, because now you've got a huge blown out right ventricle with the interventricular septum compromising the left side of the heart. And because now the left ventricle doesn't have the volume to fill, these patients start getting hypotensive. That's one of the mechanisms. So going on with this concept, I just want you guys to remember this because it'll apply over and over and over again. Let's break down this to what we use in the human body. So mean pulmonary artery pressure minus the wedge is equal to your cardiac output times vascular resistance, and you break it down, you can calculate the PVR based on this. Couple other things to think about. Within the pulmonary hypertension, within pulmonary circulation, there's a delineation of pre-capillary versus post-capillary. Pre-capillary refers to everything here. So this is the right ventricle, your pulmonary arteries, and you're getting into the alveoli with the airway compromising potentially the capillaries. But everything that occurs from this point before is considered pre-capillary, and everything that occurs beyond the bronchi, beyond the alveoli, up to the left ventricle is considered post-capillary. And this is helpful to help us decide what is causing the pulmonary hypertension, because many things is going to cause increases in the pulmonary pressure. But what you want to know is the pressure is going up because now the pulmonary vasculature is destroyed, sclerosed, overproliferated, or is there a pulmonary embolism in here? Or is it because the lung parenchyma are completely destroyed because of interstitial lung disease? Or is it something post-capillary caused by left heart failure? Is there a constrictive pericarditis? Is there fluid overload? Is there mitral valve regurgitation? Is it something that's causing elevation in pressures because of a backup, or is it something due to in the pre-capillary circulation? And based on that, we can break down the disease and guide our therapy. So it's important to know this delineation. More specifics get in here. What you will see here is there is isolated pre-capillary, many different disease groups. I'm going to get into this later. In these disease groups, you'll see an elevated pulmonary arterial pressure, but that's in conjunction with a low wedge and a significantly elevated resistance. Isolated post-capillary, just to go back to our picture, isolated post-capillary is everything that happens beyond here. So anything involving the left heart is going to give you post-capillary pulmonary hypertension. In that situation, you're going to have a high pulmonary pressure, but also a high wedge. And usually here, your vascular resistance is going to be low. And as it is with most things in life, nothing is pure pre or pure post. It's usually combined. So you'll end up having a high PA pressure, high wedge pressure, and a high vascular resistance. And this is why treatment becomes complicated. So just remember these different breakdown in terms of how we think about the disease. I alluded to the diagnosis of pulmonary hypertension. We do it with a PA catheter. In my mind, you have no idea what type of pH a patient has until you've done a right heart cath to help delineate what's going on. We can do an X-ray, we can do a CAT scan, we can do an echo, but until you get the right heart cath, you really don't know what's going on. So this gentleman is having it through his right IJ. I frequently will do it through the IJ or femoral approach in the cath lab in outpatients. A lot of people are beginning to do it from the right right forearm, but that, believe it or not, is more painful for patients. This seems to be better tolerated. And here it is what it looks like. You come in through the periphery, going through the right atrium, right ventricle, then you go through the pulmonary artery outflow tract, and you wedge the catheter distally. Again, the equation of life, Ohm's law, here we are. You will never forget this, I hope. I'm going to remind you of it. And then, what does this all mean? If you have a patient where this vascular resistance is going up and up and up and up, what is going to happen to this patient? So let's talk about this. Initially, you're starting off with relatively normal pulmonary arterial pressures. Your vascular resistance is normal, and your cardiac output is able to compensate. And to a certain point, your right ventricle is going to keep up with these pressures. It's going to keep up with this ventricle. And you, as a patient, or your patient, is going to be fairly asymptomatic and compensated. But then, as the vascular resistance hits a critical threshold, and we don't know where that is, it might be different in different people, your right ventricle can no longer compensate. And your right ventricle is going to start failing, and your cardiac output is going to start going down. And this is the difficult part of pulmonary hypertension. When patients' blood pressures are low, it's not necessarily because they're quote unquote normotensive. It's probably because their pulmonary vascular resistance is so high and their PA pressures are so high that the right ventricle can no longer compensate, and now they're going into right heart failure with Cor Pulmonale. And towards the end of the disease, this echo image demonstrates now that the right ventricle is huge. Typically, the right ventricle is smaller than the left ventricle. And what you'll see on echo is a right ventricular measurement that is bigger than the left. That's problematic, to say the least. Up here, the images, the pathobiological images, are really to show what happens in pulmonary arterial hypertension. This doesn't necessarily apply to all types of PH, but in pulmonary arterial hypertension, this beautiful thin-walled pulmonary artery that's able to let blood flow without any problems gets proliferated and obliterated. And you see all layers of the pulmonary artery now proliferated and obliterated to the point that you've got this, I don't know if you can make this out, a tiny slit of blood flow here. So having the entire cardiac output go through tiny slits like that, you can see that the right ventricle is going to work, and eventually ultimately fail. So what we're trying to do in all forms of pulmonary hypertension is get to our patients at this, ideally at this early stage, but when we do miss them, trying to get to them here before the right ventricle is blown out. Because once the right ventricle is blown out, it's very hard to get patients back. And this is demonstrated by outcomes data. Over the past 20 years, we've made significant strides in keeping patients out of the hospital and having them live longer. But when once they're sick enough that the right ventricle has failed and in the hospital, we have not impacted mortality. So once their right ventricle is blown and they're hospitalized, they will die. They have an 8% mortality rate. So we're trying to avoid this decompensation phase. So early diagnosis, early treatment is really crucial here. And I'll talk about how we can identify these patients. So I already talked to you about what Cor Pulmonale is. It's failure of the right ventricle, and it's caused by pulmonary hypertension, and it's not due to diseases of the left heart. It's really due to diseases of the lungs, Cor Pulmonale, as it stands. Here's yet another swan. I don't want to talk too much about it, but I do want to talk about the World Health Organization of grouping of the various types of pulmonary hypertension. Their disease based on histopathology, their natural history, and primarily their response to therapy. So most diseases in one group will respond to one type of therapy versus other types of therapy. So that's where the grouping comes in. Going back to my initial concept that pulmonary hypertension is really the overriding arch picture here, and PAH is one subcategory. Pulmonary venous hypertension or cardiac hypertension is a second subcategory. PH due to lung diseases and hypoxia is yet another category. Thromboembolic or obstructive disease is a fourth category. And then there's this miscellaneous, unexplained or unclear group of disorders that cause PH. So yet another description of this, with the miscellaneous group being very, very nebulous. I want to point out here the primary causes of pulmonary hypertension are either, the primary causes of pulmonary hypertension are either due to volume overload, left heart failure, or it's due to COPD, interstitial lung diseases, and then this funky miscellaneous group that keeps getting recategorized, re-diagnosed with every symposium. So let's talk about group 1 PH, pulmonary arterial hypertension. What we are learning about PH is that there's a big group of patients who have idiopathic or unexplained PAH, but when we delve deeper into these patients and do genetic testing, we find that they have genetic abnormalities. Patients that we thought who were just unexplained or idiopathic, when you look at them, turn out to have most commonly the bone morphoprogenic receptor abnormality too, and there's a whole slew of other genetic abnormalities that are being identified. So that's interesting to know, and it's important to know because it has significant meanings for family members. This genetic abnormality is autosomal dominant, but its penetration is very, very variable. So just because one family member has it doesn't mean that everybody else is going to have it, but it does mean that patients' family members should be screened annually for pulmonary hypertension. Drug and toxin induced is the next big category. Back 20 years ago, the maybe 30 years ago now, the fen-phen outbreak, anorexigen outbreak, really resulted in a high incidence of PAH. And periodically, drug companies introduce new anorexigens. Benfluoramine was a new one that was introduced probably about 5-10 years ago, and that obviously also causes PAH. So stay away from anorexigens. And then rapeseed oil, if you take it too much, cocaine, amphetamines, those are all associated with causing pulmonary hypertension. For us in an academic center, what we see most here at Georgetown is this top 3 categories: connective tissue disease. So systemic sclerosis, scleroderma, that is the leading cause of pulmonary hypertension that we would see here in an outpatient setting. Patients with HIV infection are at risk for it. We're not quite sure why, and it's not necessarily the duration of HIV. It is not necessarily the treatment or under treatment of HIV, but for whatever reason, patients with an HIV infection, controlled or not, are prone to getting PAH. It's a small subset, but enough that if you have a patient with HIV who's now got exercise-induced dyspnea that is unexplained, I would suggest getting an echo looking for PH. Portal hypertension is very common. We are a transplant center, liver transplant center. So a lot of our cirrhotic patients that get transplanted, even though we screen them pre-op, oftentimes we do get surprised that when they didn't have pulmonary hypertension pre-transplant, on the operating room table, we float this one and whoa, now they have pulmonary hypertension. So the case gets canceled. They brought up to the ICU and we have to figure out and treat their portal hypertension. So that's very common. Congenital heart diseases, thankfully, we're not seeing a lot of it here in the United States and in the developed world, but in China, congenital heart diseases is a leading cause of pulmonary hypertension. And then worldwide, especially in endemic countries, schistosomiasis is the leading cause of pulmonary arterial hypertension. I have yet to diagnose a case of schisto. I am looking for it because it is treatable. It is treatable. And then there's another category of pulmonary veno-occlusive disease, capillary hemangiomatosis. These are incredibly rare. I'm not going to get into that. But for our purposes at Georgetown, keep in mind connective tissue, HIV, and portal hypertension. So I want to rewrite this equation so that we can think about what else could cause pulmonary hypertension. So we said mean pulmonary artery pressure greater than 20, okay? And when you look at this equation, you can see increased cardiac output, increased PVR is going to raise your PAP. But similarly, wedge, volume overload, is going to raise your pulmonary arterial pressures. So this was really just a reminder slide. As I keep going through this, I want you guys to keep remembering this equation. Delta P equals flow times resistance. So let's talk about, I'm going to take you back to pulmonary arterial hypertension specifically. And again, this is a type of pre-capillary hypertension. I'm sorry, I'm distracted. I'm getting a patient ICU. We'll ignore that for now. Okay, so again, to remind you of the definition, you want to have an elevated PA pressure, mean PA pressure, elevated vascular resistance, and a normal arterial occlusion wedge pressure. In addition to that, in addition to having these hemodynamics, you want to make sure that there isn't anything else going on. So other causes of hypoxia are not big players here. So if your patient's got scleroderma and they also have a little bit of ILD, interstitial lung disease, it's little and it's not the dominant feature. Because if the dominant cause of the pulmonary hypertension is destructive interstitial lung disease that's destroying the pulmonary vasculature, really the only treatment for that is lung transplantation. But if the interstitial disease is really, really mild and minimal and their pulmonary pressures are high, then you want to go after the pulmonary arterial hypertension. Okay, so you want to rule out other causes of PH. I think you guys have seen this enough, and hopefully you will not forget it. The main point, the secondary main point of this slide is all of our data for treating pulmonary arterial hypertension is based on a mean PA pressure of 25. The definition that the mean PA pressure is 20 just came about 2 years ago, and there's no studies to suggest that patients with mild PH between 20 and 25 should be treated. For these patients, these mild patients, the recommendation is we just follow them. Annual echoes to make sure they're not progressing. But once they hit a mean PA of 25, then we start therapy. So idiopathic PAH, very, very rare, maybe 15 per million for all PAH cases, but 6 million for idiopathic, so incredibly rare. It is female predominant and fairly young. You guys might consider this old, but from my perspective, this is a young person in the prime of their life. Very frequently, you'll see young women, young mothers who are now diagnosed with PAH. Connective tissue disease is very, very common, and systemic sclerosis on autopsy, up to 80% of patients will have PAH. What's interesting about this disease is when you go to China, in terms of connective tissue diseases, lupus becomes the cause of pulmonary hypertension. And in the United States, it's rare that not rare, but not as common as systemic sclerosis that lupus patients get PAH. Mixed connective tissue is more common, in fact. So systemic sclerosis, then mixed connective tissue, and less likely lupus and rheumatoid arthritis patients get PAH. HIV, this number keeps changing. It's 0.5 to 2% of patients with HIV end up having pulmonary hypertension. Again, it's unpredicted exactly who will get it, but the risk factor in and of itself is there. And just to be very clear, I would not do routine screening echoes on all patients' HIV, not routinely. I would only do it if an HIV patient does not have other explanations. Common things occur commonly, and in our HIV population, it's either infection or as they're getting older, it's the usual left heart disease. But if you cannot explain it on the basis of those, then get an echo looking for right heart function, pulmonary hypertension. Portal hypertension, I've also mentioned before, it's a big part of our, we have a skewed population of this at Georgetown. Okay, and then the congenital heart diseases, again, not so common with us. Usually in the United States, the congenital heart disease patients get referred to our pediatric cardiologists because they're the ones who really focus on managing these patients, believe it or not, for life. So VSD, PDA, and even those that have got repaired ASD, I tend to have these patients followed by my congenital heart disease specialist, and they're housed in Children's Hospital. So this is the normal pulmonary anatomy, if you like. When you look at it at a microscope, you see this beautiful thin-walled alveolar capillary blood-brain blood barrier, very single cell wall. This is a pulmonary artery, thin-walled, with good blood flow through it. This is an artery caught sort of cross-sectional, not cross-sectionally, longitudinally, but you can see it's just thin-walled, and the lung parenchyma are beautiful and open. This is a progressive proliferative vasculopathy. You can see that all of the layers are completely getting destroyed. There's a proliferation of smooth muscles, collagen is infiltrated, and again, the lumen of the pulmonary is this tiny slit, and there's a congregation of red blood cells, and these patients, you can see why they're prone to having in situ thromboses. Let's talk a little bit about the good players and the bad players. The bad players, the yin and the yang, so to speak, normally exist they coexist just like everything in our body. The good and the bad balance each other out. You don't want to have too much of a good thing. You don't want to have too much of a bad thing, because then you start running into problems. So the vascular smooth muscle cells proliferate. There's increased platelet aggregation, not just because of abnormal anatomy, but the platelets themselves become dysfunctional. Increased numbers of fibroblasts become an issue. What we're trying to do in treating pulmonary hypertension is I'm going to go back, we're going to control these bad players, so to speak, and promote these good players to increase the balance. In PH, what we've known in autopsies is that prostacyclin levels are down, nitric oxide levels are down, and then endothelin levels are up. So what we try to do is we try to block endothelin with various medications, and we try to promote prostacyclin levels and promote nitric oxide levels. There's a lot of research going into serotonins and everything else, but so far our only therapies are on these three pathways. Okay. I mentioned the balance of the vasoconstriction and fibrosis and the intravascular thrombosis. We're trying to balance these out. This is a very complicated slide, but I will point out that it is old, 2006. So 15 years later, I did not put up the most recent slide here because it's even more complicated and difficult to understand. I just want to point out to you that this interplay between the endothelium and the smooth muscles is really complex, and it's hard to keep it straight, just like anything else that we learn in medicine. Before I go much further, any questions so far on pulmonary arterial hypertension? So that's only what we would call group 1 of all the different types of PH. Okay, I'm going to keep going, and then you guys can stop me at the end. I'll finish a few minutes early, Carrie, and you guys can ask me questions. So let's talk about group 2, pulmonary hypertension due to left heart disease. So if you've got HFrEF, HFpEF, if you've got mitral regurgitation, if you've got pericardial disease, these will always cause post-capillary pulmonary hypertension with backup of fluid, backup of blood into the lungs. And in the hospital, remember this equation from before, this wedge pressure. In the hospital, when you get an echo and you see elevated PA pressures or elevated pulmonary pressures on the echo, the most common cause of it is going to be either volume overload, because we hydrate our patients, that's our gestalt, and it's not a bad thing, but it's typically the most common reason why patients in the hospital get diagnosed with pulmonary hypertension. And then the second most common thing in the COVID era has become lung diseases, specifically interstitial lung disease, pneumonia, those types of things will also elevate pulmonary pressures. To go back to how do you treat patients with PH due to left heart disease, your goal is going to be to fix the heart. If it's HFrEF, you do afterload, you try to improve cardiac output, left ventricular cardiac output. If it's volume overload, you diurese or you dialyze. If it's mitral valve issues, you try to fix the mitral valve. If it's pericardial issues, I've sent patients for pericardial stripping to fix their pH. At the end of the day, it's really treat what's causing the pH. It's especially important here. I would not put these patients on sildenafil. You know, you have a patient, you see in the outpatient setting, and this used to be the case 20 years ago, 15 years ago. Docs would look at the echo and say, hey, you got pulmonary hypertension. Let me give you sildenafil. Be very careful with that because it's a pulmonary vasodilator therapy, any kind, can throw off the balance in the lungs, and then you can inadvertently push your patients into pulmonary edema, and on occasion that can be life-threatening. Most of the time it simply causes pulmonary edema slowly and gradually. Patients get more hypoxic, more dyspneic, and then I see them and then I stop the sildenafil, but occasionally you will have life-threatening pulmonary edema. So be careful about pulmonary vasodilator therapy in this group. Group 3 is pulmonary hypertension due to lung diseases. So here you want to treat the COPD, you want to treat the interstitial lung disease, you want to treat the lymphangioliomyomatosis, that's typically lung transplant. You want to fix the sleep apnea. That's a very common cause of pulmonary hypertension. I will point out to you, if in the outpatient setting, you have a patient with sleep apnea or obesity hypoventilation, expect them to have some degree of pulmonary hypertension. They will have mild, perhaps moderate pulmonary hypertension, but they should never have severe pulmonary hypertension. If these patients with any of these categories, in fact, if any of these patients have severe pulmonary hypertension, they have something else going on, probably a vascular component that deserves vasodilator therapy. Most of the time, expect a little bit of pH for these patients. A mean PA pressure of 25, 30, I would say is within the normal realm of expectations. Okay, so for these patients, treat the lungs, provide them with oxygen, get their OSA treated with CPAP or BiPAP as the case might be. Now, group 4, this is kind of an interesting one. If you guys are eating, I'm going to be showing some pictures that might make your tummy uncomfortable. So be warned, but this is a cool group of diseases. I've only put the name chronic thromboembolic pulmonary hypertension up here, but the new term is chronic pulmonary hypertension due to obstructive diseases. And we all know that clots can obstruct. And this is the picture. So what this picture is of a patient who's had recurrent PEs in the pulmonary arteries, and those recurrent PEs have caused pulmonary hypertension. And this patient has gone a pulmonary artery endarterectomy, which is literally you cut open the cut open the chest, put the patient on bypass, first clean out the right lung, then clean out the left lung pulmonary artery. And this is literally a cast of what's going on inside of the lungs. And what's interesting here is this is not just a regular old fibrin cast. This tissue is actually alive. This is actually multiplying, growing tissue. So this is different than patients who get a little bit of a PE, and they might have an isolated PE, and eventually they get a little bit of a fibrin cast in that isolated area. But these patients, not only are they getting multiple PEs, that the PE is not quiescent after time. The PE after time is actually alive. The hard part is who's very difficult to distinguish, who's going to end up like this versus just have a little subsegmental PE and do okay. It's a very tough judgment call. As you can imagine, these patients, they need to be anticoagulated for life. They will have recurrent PEs. If you've got CTAP, even if you have not identified the cause of the CTAP, they've had clots, they're going to get clots again. They've got to be anticoagulated for life. And it's a very well-known data. It improves survival when you anticoagulate them. We strongly recommend that they all get IVC filters, obviously, to prevent any further injury. And then the decision becomes who gets thromboendarterectomy. I send all of my patients to thromboendarterectomy centers. There's now many of them throughout the country. San Diego is the leading one, I would say, UC San Diego. Locally, I would go to Duke. and that's as local as it gets. Temple is beginning to do these, but this is a very, very high-risk surgery, putting patient on bypass and doing both sides of the pulmonary circulation. This is a patient of mine, not as impressive as this one, obviously, but this patient went from having high oxygen demands, not being able to work after the surgery. He's back to full work and doing really well. But you can imagine why you would not be able to breathe and need oxygen when you have this kind of clot or fibrin growing tissue sitting in your lungs, pulmonary arteries, let me be more specific. And then the final category, group 5, unclear or multifactorial etiologies of pulmonary hypertension. End-stage renal disease is in here, hemolytic anemia, sickle cell, beta thalassemia. Unclear how these things end up causing pulmonary hypertension. They do, and we struggle to treat them. And they're still, I give these patients in these categories PH therapy, if you like, but I do it with hesitation. And I do it because I'm running out of ideas as to how else to treat them, and these patients are desperate for therapy. Okay, so just to recap, the WHO groups, to simplify them, we've got the PAH group. The group 2 is left heart diseases. Group 3 is due to lung, obstructive sleep apnea, COPD. Group 4 is primarily in our world DVT-PE, and group 5 is the miscellaneous category. One interesting group under group 4 is the one that presents with acute right heart failure. That could be a massive PE. And in a university tertiary care setting, what we see occasionally is cancer emboli. So with renal cancer and occasionally breast cancer, those you get microscopic tumor emboli to the lungs, and that can present as acute Cor Pulmonale. And in the malignancy case, we really have not much to offer those patients, and it's a very sad, rapid death that we see. But that's the basics. I'm going to just touch upon the presentation and diagnosis of pulmonary hypertension. Very briefly, the presentation of it is a Trojan horse. Because, again, I mentioned earlier on, the pulmonary circulation has got such a big reserve. By the time that reserve is lost, patients, the damage is done. And patients don't really know what's going on, and physicians rightfully aren't going to jump to diagnosing a rare disease from the get-go. And on average, it takes 2.5 years for a patient with PH to be diagnosed. And I'm not saying you should jump to an echocardiogram in every patient with shortness of breath, but I do think that if you don't have a clear-cut explanation, you shouldn't be attributing it, oh, you're out of shape, oh, you're older, oh, you've got asthma. All of my patients with PH have asthma that then turn out to be, nope, it was PH. So just keep that in mind. High index of suspicion. Do your basic usual workup of whatever it is that you do, chest x-ray, good history taking. And then if you're still left with, I don't have an explanation, you might do PFDs, and then eventually do an echocardiogram. But ultimately, the way you're going to diagnose pulmonary hypertension is going to be a right heart cath. Symptomatology, very generic: breathlessness, fatigue. Syncope, I would alert you to keep an eye on, because young patients compensate really well, but when they exert, they have near syncope, and that's because their right ventricle cannot overcome the resistance in the lungs. And then as they're pushing themselves, they cannot generate enough cardiac output. They don't get blood to the brain. Next thing you know, they're having a syncopal episode. So syncope, PAH, advanced PAH should be in the differential. I don't want to spend too much more time on the diagnosis of this because we're running out of time here. I'll show you some cool pictures if you like. This is a partial PE blocking the left pulmonary circulation. This is an angiogram in a chronic PE case where you see the pulmonary arteries are huge, and then but there's these cutoffs, so you see no blood going beyond those obstructions. So we don't do pulmonary angiograms anymore because we're so good at getting, our radiologists, I should say, are so good at diagnosing PEs with a chest CT. But in a lot of institutions, chest CT reads is only reader dependent. So angiograms still tend to be the diagnosis of diagnostic methodology of choice for looking for chronic PE. A brief word about survival. The original NIH registry back in the 1980s, they had 200 patients roughly with idiopathic pulmonary arterial hypertension. Without treatment, their median survival was less than 3 years. So it's a horrible disease. This median survival still is the case for patients if we don't treat them. So it's important that we treat these patients. Without therapy, these patients will die. And even with therapy, the disease is progressive. So we want to get these patients to a treatment center as expeditiously as we can.